Good afternoon, everyone. I'm Dr. Faisal Ozair, and I'm working as a consultant endocrinologist in Epsom General Hospital, London. First of all, I would like to thank the organizers for giving me this opportunity to share my experience and knowledge with you all. I am proudly an ex-MCM myself and feel excited to doing this session with you. I was asked by organizers to prepare a lecture for students preparing for the exam, and I hope that you find it quite helpful. In the first few slides, I discuss basic physiology of endocrine system, which will help you to understand the pathology easily. And then I'll go to the endocrine emergencies. So I'll start with my talk. So basically, what is endocrine system? It's a system of glands that regulate and affect all other body systems through messenger called hormones, and it's all not connected to without any. They are connected without a wire, just like Wi-Fi system. And the main function is to preserve homeostasis, to keep balance in the body. It should be very fine balance. So if you have balance either high or low levels of your hormone, you start feeling unwell. And usually they work through a system called positive and negative feedback system. I'll just go through definition. Negative feedback work like the thermostat, in which a buildup of product will eventually shut off the builders. For example, if you set a thermostat 25 degrees centigrade, as long as the temperature is below, it will keep on working. But once it's touch, it will stop automatically. Example is thyroid stimulating hormones and ACTH. They will eventually stop when the thyroid or the cortisol levels in your body is high. And positive feedback, rare, but example is when you have lots of during the labor, the uterine contraction will, once they started, it will further enhance the other till the baby is delivered. So these are the major endocrine glands. So hypothalamus is the control room, basically work in connection with the both neurological as well as the endocrine system. Then the pituitary gland. Pituitary gland is called the master gland. All the hypothalamic function run through the pituitary gland. And the others are pineal gland, thyroid, parathyroid glands, adrenal, pancreas, ovaries, and testes. This is a very interesting slide, almost cover 50% of your endocrine system. It's called hypothalamic pituitary axis. As I said earlier, hypothalamus is the main center, which releases different hormones called hypothalamic hormones, which run through the small blood vessels to the anterior and pituitary gland. So anterior pituitary gland is the main gland which releases different hormones and act on the target organs. So these are the target organs. Then the important anterior pituitary hormones are growth hormone, which helps to bone muscles and other organs growth. Then the prolactin helps in lactation, gonadotropins called LH and FSH, which act on ovaries and testes respectively to produce estrogen and testosterone. Then ACTH work on adrenal cortex to produce cortisol hormone. TSH work on thyroid gland to produce thyroid hormone. And then this is the posterior pituitary gland, which works on the kidneys, producing ADH, antidiuretic hormone, to conserve water. And then the oxytocin helps in the milk production as well as the uterine contractions. So the endocrine emergencies, why are we discussing this today? Basically, endocrine emergencies are relatively rare if you compare to the diabetic emergencies, which everybody deals commonly in day-to-day practice, but endocrine emergencies are rare. Even in England, it's around 1.3% of critical care patient comprises of endocrine emergencies. So although it is uncommon, many of these emergencies are potentially life-threatening. And most endocrine crises are triggered by secondary insult, commonly by infection, and clinical features are often vague and difficult to pick up. So once the you can't pick up the symptoms, disease. It results in delay in both diagnosis and treatment and can be associated with very high mortality rate. Endocrine emergencies often encounter in patients with either known endocrine pathies, means if somebody already have pituitary adenoma, Addison disease, if they got unwell, they may come in with endocrine emergencies. But sometimes it may be the initial presentation. Patient fit and well otherwise suddenly came in with shock, and then you found out that patient has Addison crisis or severe hypothyroidism or any diabetic emergencies. So what I'm going to discuss today, so there are so many endocrine emergencies exist, and in half an hour session, it's not possible to discuss all of the emergencies in detail. So I'll just try to touch base with all the common medical emergencies. And if you want, I can do in a separate lecture other emergencies in detail. So what I'm going to discuss today: thyroid storm, myxedema, pituitary apoplexy, adrenal insufficiency, pheochromocytoma, diabetes insipidus, and hypercalcemia. So I start with thyroid. So basically, the enlargement of thyroid is called goiter. It could be either diffusely enlarged or nodular. So the next picture, I just show the picture. This is a classical example of diffuse goiter, which thyroid is diffusely enlarged in both, and you can appreciate some bulging of eyes as well in a young female, which is most commonly due to Graves' disease. And this picture shows all of the thyroid is enlarged, called goiter, but one large nodule is quite prominent. This is called single nodular goiter. And on this other picture, you can see goiter is quite enlarged. But when you feel, you see multi-nodules, which means more than one nodule, and it is called multinodular goiter. The causes are most commonly caused is Graves' disease. This is the most common cause of hyperthyroidism is Graves' disease, which is comprises of 80%. It's autoimmune process, followed by toxic nodular goiter, and the rest are few which we can read in these slides. I just want to show you a few. I'm sure you have already seen, but just to revise, the eye signs in Graves' disease, which are very classical, and you should appreciate these signs, especially in the exams. And if you're preparing for membership exam or any license exam, these pictures will come in your exam as well. So this is called pre-tibial edema, when you see the swelling just beneath the eye, and then the chemosis, the redness, lid retraction. You normally see the eye, this upper eyelid should cover the upper part of this area, but you can see the white area above. This is called lid retraction or lid lag. Then it's quite prominent, called proptosis. And this is called ophthalmoplegia, when thyrotoxicosis is so severe that the eyes muscles are weak or paralyzed, and they are fixed, they can't move. So that's called ophthalmoplegia. So this is a very important slide again. It's showing the thyroid control, which is very similar, which I discussed earlier. This is the hypothalamus, which releases hypothalamic releasing hormone via these small blood vessels to the pituitary gland, anterior pituitary gland, and it releases thyroid stimulating hormone. And thyroid stimulating hormone act on thyroid gland to produce T3 and T4, the thyroid hormone. So once the thyroid hormone is within range, it works normally. But if it is, for example, thyroid function is more than the desired level, it automatically switched off. That is called negative feedback system. So it will switch off the anterior pituitary as well as the hypothalamus and ask them not to produce further TRH or TSH. And if it is low, it vice versa. So once thyroid function is low, T3, T4 thyroxine and T3 levels are low, it will ask pituitary to produce more TSH as well as the hypothalamus to produce more TRH. So what is thyroid storm? So it is an extreme form of thyrotoxicosis manifested by marked delirium, severe tachycardia, vomiting, diarrhea, dehydration, very high fever. So in summary, all the metabolic system is at the highest level. It's rare, but mortality can approach to 75%, and with death predominantly due to cardiac complications. What are the precipitating factors? Either surgery, trauma, myocardial infarction, pulmonary embolism, DK, or most important, discontinuation of anti-thyroid medication. Certainly put you on thyroidostorm, and rest are a few which you can read. So how do you diagnose? Apart from clinical, you rely on the blood test, which classically show increase, very high rather, T4 and T3 levels with suppressed TSH. As I said earlier, I'll just go back to the previous slide. So once your T4 and 3 are very high, so it automatically, the TSH will suppress. So this is a classical presentation of hyperthyroidism or thyroid insult as well. The rest are non-specific: hyperglycemia, hypercalcemia, elevated alkaline phosphatase, and cortisol may be high. So it is an endocrine emergency. So how do we treat? So treat is, it should be managed in IC. The supportive care start with hydration, cooling, antipyretics, avoid aspirin because it releases thyroid hormone from the binding sites, and multivitamins. And the treatments option are, so the medication, the specific medications are, still we rely on two most importantly used medications are either propylthiouracil or carbimazole group. So these are the dose which you can see in further details. So basically it can inhibit the hormone synthesis and decrease the T4 to T3 conversion as well. T3 is more potent, so this propylthiouracil is more helpful in treating this condition because not only inhibit the hormone synthesis, which both of them do, but it also decrease the conversion of T4 to T3, so it's more helpful. The other thing which you can use are the legal solution, sodium hypothalamic, and then the beta blockers. This is very important because all the adrenergic system are fully activated. So you have to treat with beta blockers, otherwise symptoms will not settle. So treatment of choice beta blocker is propranolol, is still commonly used. So it helps the reducing the beta adrenergic system. Also helps to decrease conversion of T4 to T3. And the doses are here. The other beta blockers can be used on atenolol, metoprolol, nodular, and if you want to go for intravenous, esmolol is the drug of choice. Sometimes patients are allergic, so you can't use anti-thyroid medication. So what are the other options are? Either you can use lithium, potassium perchlorate, and cholestyramine. And sometimes glucocorticoids, steroids may help. Okay, so now move on to hypothyroidism, the other extreme form of hyperthyroidism. So what are the causes of hypothyroidism? Either it is primary, whenever you see the terminology in endocrinology, primary or secondary, let's just go back. The primary means the gland itself is affected. So whenever you see the terminology that primary means the gland is affected. If it is called secondary hypothyroidism, it means either the pituitary or the hypothalamus is affected. So it will see the same, we use the same terminology in adrenocortical system as well as the gonadotrophic system as well. So just bear in mind. Just go back to hypothyroidism. So in next slide, I'll just show you the blood picture, which help you in your exam as well as in your clinical practice as well. So common cause of hypothyroidism are, if it is primary disorder, Hashimoto's, the autoimmune disease is the commonest. Otherwise, post-radiation therapies or post-surgical ablation is fine. And then the secondary causes either hypopituitarism or hypothalamic effect. Okay, so this is the blood picture I was talking about. This is very classical. Just remember, it will help the whole of your life. So if you see the T4 and T3 is low, it means it is hypothyroidism. Then you have to decide whether it's primary or secondary. If TSH is high, means pituitary is working quite well, so it is called primary hypothyroidism. It means the the thyroid gland is affected, and this is compensating by the pituitary to release more thyroid stimulating hormone to compensate, but because the gland is affected, so nothing will happen. So you will see the picture: low T4, low T3, and high TSH. And in the next slide, if you see, the T4 is still low, T3 is still low, but TSH rather than high is low. It means the pituitary or the hypothalamus is affected. So that is called secondary hypothyroidism. Okay. So this is just the picture. Just show the picture of this patient before and after treatment. You see all puffy face, the eye like slight ptosis, basic metabolism is affected, and once is cured, you see the complete different person here. So the extreme form of hypothyroidism is called myxedema coma. Is rare, but again, it's potentially life-threatening manifestation of decompensated hypothyroidism and has mortality as high as up to 20 to 60%. It's characterized by altered consciousness, plus manifestation of severe hypothyroidism, hypothermia, dry skin, hair loss, sluggish tendon reflexes, edema, and macroplegia, and pleural and pericardial effusion as well. After a clinical examination, you will go to laboratory tests, which show classical low T3 and T4 and very high TSH. Others are non-specific but may present hyponatremia, hypoglycemia, transaminases, CPK and LDH. These are the enzymes can be raised as well. And ECG show Sund's bradycardia, prolonged QT interval, and low voltage. So ECG spikes. Treatment are vary, but you have to start with the airway stabilization. Make sure patient have adequate oxygenation, vitals are stable, cardiovascular status should be monitored closely, and gradually reform with gentle passive external rewarming. And the specific treatment is levothyroxine, which is T4, 250 microgram IV for 3 days, and then 100 microgram all patients previous dose if it is already known hypothyroidism. We may sometimes use T3 leothyroxine as well, and then switch back to T4. Okay, so now we move to the pituitary gland, which, as I said earlier, is called the master gland, which control most of the other endocrine system in the body. And it is a very small pea-sized gland situated below the hypothalamus. And this has a very important anatomical location. I'll show you. So this is the anterior and posterior lobe of pituitary. This is optic chiasm, and this is mammary body. So this is the hypothalamic area, so which releases these inhibitory or releasing hormone, growth hormone, corticotrophin, so which ultimately affect the anterior pituitary gland. So these are the inhibitory and releasing hormone working through the small blood vessels to the anterior pituitary gland to release all these hormones, growth hormone, prolactin, TSH, ACTH, FS, and LH. Normally, prolactin is the only hormone which is inhibitory hormone, prolactin inhibitory hormone rather than releasing hormone. And this is the posterior part which releases, so from the hypothalamus releases ADH and oxytocin. This is just the anatomical equation. Why it's so important to discuss this pituitary anatomy here. So this is the pituitary gland. It is very close to the optic nerve. And if you remember from your anatomy knowledge, the optic nerve have two fibers, nasal and temporal fibers, and nasal fibers cross and go to the opposite side. And if the pituitary gland is enlarged, it's mainly affected the nasal fibers of the optic nerve, which resulted in bitemporal hemianopia. So both the temporal side visual field is affected. So what is a pituitary apoplexy? Basically, it is a clinical syndrome resulting from acute hemorrhage or infarction of the pituitary gland, characterized by severe headache, vomiting, visual disturbance, ophthalmoplegia, most commonly third nerve, meningism, signs of meningism, fever, decreased consciousness, or even death. What are the predisposing factors? It's a long list, but commonly are arterial hypertension, cardiac surgery, diabetes, acromegaly, anticoagulation, sometimes with dynamic pituitary test can cause. How do you diagnose? Diagnosis should we rely on the imaging, CT scan or MRI. I just put MRI scan, just try to showing you what is pituitary apoplexy. If you can appreciate, this is the sagittal and the coronal view. So if you see, this is the brighter area. This is the area of pituitary gland. which is hyperdense, very bright, comprises of all blood. And if you see, this is the optic nerve. It's very close to optic nerve. So once optic nerve is affected, you may have the visual symptoms as well. And it's very close to the cavernous sinus. Cavernous sinus, as you remember from anatomy knowledge, contains third, fourth, and sixth nerve. So if it is big, it will affect third, fourth, and sixth nerve as well. And this is the internal carotid artery. So many key structures are closely located in this small area. That's why it's so important to diagnose this condition early and treat. Otherwise, you may lose your patient. So this is the other view, which shows again the pituitary apoplexy, blood, basically blood within the pituitary gland. And treatment, careful monitoring of fluid and electrolyte balance. It once affects the pituitary gland, it will affect all the hormones which I discussed, from growth hormone to acid to cortisol, thyroid. Most importantly is the corticosteroid hormone, followed by thyroid hormone, which breast can be weak, but without steroid you can't survive. So replacement of the deficient hormone, especially corticosteroid. Consider pituitary surgery as well, and long-term monitoring of hypoadrenalism and refer for recurrence of pituitary adenoma is possible. So when should we refer to the surgeons? So if patient has diminished level of consciousness, hypothalamic disturbance, or visual impairment. If you have all these, if your patient have these symptoms, you should talk to your neurosurgeons immediately, and they may need to do the neurosurgical intervention with in new time. But if the patient is stable, hemodynamically stable, if you start on steroids, then the patient can wait and discuss a bit later. But definitely you have to involve the neurosurgeons in either case. Okay, so now we move on to the cortisol secretion. Cortisol secretion, again, very important hormone. And again, this is a very good picture, if you appreciate from the previous slides, working almost very similar fashion to the thyroid. If you can see, this is the hypothalamic area, which release corticotropin releasing hormone via the small blood portal capillaries into the anterior pituitary gland, and releases ACTH, adrenocorticotropin hormones, and it works on the adrenal cortex to release cortisol hormone. This is normal process. This is the way normally it works. If you have very high steroid in your body, called Cushing disease, so what happens? So it will switch off. This is called negative feedback. Again, same principle. So it will switch off the pituitary as well as the hypothalamic area, and it will not release any further ACTH or CRH level. This is the outermost is adrenal cortex, and inner is adrenal medulla, which again release very important hormone. I'll discuss later. Before we move to the next slide, this is very important graph. This will help you in the rest of your life if you want to practice endocrinology or any general medicine field. So cortisol secretion is always in circadian rhythm. If you see, this is the time clock from 0 to 24 hours, and this is the cortisol level. If you see, the cortisol is the peak at around 8 to 9 a.m. So we, as endocrinologists, we always ask to check, if you want to check cortisol, ideally it should be early morning, 8 or 9 a.m. because levels vary so much so that if you check any cortisol level around midnight, you may got the quite different result. So that's why timing is so important. So what happens with adrenal failure? Basically, if it results in adrenal insufficiency, lead to wasting of insidious wasting disease, and stress failure result in adrenal crisis. It is life-threatening. You can't survive without corticosteroids, and it's very critical. So as I said earlier, in endocrinology, you always come with the terminologies primary and secondary disease. So primary is when the gland is itself affected, and secondary when it affects either the pituitary or hypothalamic area. So if it is primary, it is called Addison disease. Primary adrenal insufficiency is called primary Addison disease. It is caused by inability of adrenal gland to produce cortisol, aldosterone, or both. The hypothalamic pituitary axis will remain intact in this situation, and it's characterized by orthostatic hypertension, hyponatremia, and hyperkalemia, mild metabolic acidosis, and hyperpigmentation of the skin. I don't know whether you remember from your physiology knowledge, if the glands is affected, you will have more ACTH, and ACTH stimulate melanin stimulating hormone, and patient have high pigmentation in the skin. And whenever in any exam situation, if you come with the data hyponatremia and hyperkalemia, always think adrenal involvement, and as well as in clinical practice as well. Although in clinical practice, around 60% of patients have this classical hyponatremia and hyperkalemia, but in the exam situation, it is very common. So always bear in mind. So these are the three classical picture of Addison disease. You see very high pigmentation in this area as well, and in the mouth, you can see the buccal pigmentation as well. Secondary is caused by dysfunction of hypothalamus or pituitary, as I discussed earlier, with the normal adrenal gland. It may result in hypotension and hyponatremia, but the potassium and hydrogen levels are normal because the renin-angio system, which is working around the kidney or adrenal, is doing well. So you may not found significant orthostatic hypertension or as well as the hyperpigmentation if it is involved the hypothalamus or pituitary gland. The commonest cause are abrupt stopping of exogenous source of glucocorticoid. For example, patients have long-term conditions like rheumatoid arthritis, any dermatological condition, inflammatory bowel disease, or COPD. They may be on long-term steroid for longer time. If they stop suddenly, the hypothalamic pituitary axis is already shut off. So body have no steroids, so they end up in adrenal crisis very quickly. So this is most commonly caused. However, the other causes are primary Addison disease, means gland is affected. In the Western world, autoimmune is the most common. However, in the developing countries, tuberculosis and the fungal infection are the still commonest causes of hypoadrenalism. Others are hemorrhage, metastasis. Drugs are quite common as well. And then the secondary cause, either pituitary or hypothalamic area affected as well. So how they present? So if patient came in with adrenal failure, they are quite unwell, and your clinical judgment really makes a huge difference. So patient came in with weakness, fatigue, all non-specific symptoms. That's why it is so important. You should know all these conditions, because if you don't have background knowledge, you probably it's quite difficult to pick these conditions. So patient may come in with weakness, fatigue, anorexia, weight loss, nausea, vomiting, other very non-specific symptoms, dizziness, orthostatic symptoms, hyponatremia and hyperkalemia, as I said, is a very classical combination, hyponatremia and hyperkalemia, hypertension, shock and even death, and hyperpigmentation. So how do you diagnose? If you see patient in emergency, you have to treat. So just take a blood and send more cortisol and ACTH and then treat. But if the patient is hemodynamically stable, it can wait. So depend on the patient condition. If this patient is stable, you send the blood sample. If it is less, cortisol level is less than 83, most likely it is Addison disease. However, if it is more than 500, it's almost ruled out. If your patient results are in between these two areas from 100 to 500, then you have to go for a condition called test called short cervical test, where you give artificially ACTH to stimulate the adrenal gland and check the levels after half an hour. If it is level is more than 500 or 550, this adrenal insufficiency is excluded. However, if it is less, then most likely it is adrenal insufficiency. So you will hear in your practice as well as your in the ward round, you see your bosses are often asked for short cervical test if they worried about adrenal insufficiency. So what's the treatment? So they are steroid deficient. So steroid is the treatment of choice. There are different forms, either dexamethasone, prednisolone, or hydrocortisones are available. So you can use either of these. So once you can start either dexamethasone, and once the ACTH test, the short cervical test completed, you can start You can't wait for the blood test results to come back. You start giving treatment. Hydrocortisone can be started 50 milligram IM 6 hourly, unless the test result available. If the test results are normal, you don't need to continue. You can stop. But if it is low and highly suspicious of adrenal disease, continue. So once patient start eating, drinking, feeling well, you cut down to 20 milligrams, and then continue on 10, 5, and 5 of 10 milligram in the morning, 5 at lunchtime, and 5 evening of hydrocortisone for rest of the life. So adrenal, the severest form of adrenal failure is called Adrenal crisis, which is again a medical emergency. Patient present with hypotension, stupor, delirium, severe abdominal pain, nausea, hyperkalemia or hypernatremia. We start with hydrocortisone, IM or IV straight away. Start with dextrose or normal saline to hydrate. And then if they're already on hydrocortisone, just double this dose of steroid for 5 days and ask them to wear a bracelet, which will which help the paramedics or any people around them know that this patient has Addison disease and they need steroid straight away. So they can't wait. Okay, so next we move to the condition called pheochromocytoma, which is due to hormones produced from the adrenal medulla. And this is mostly benign and produces large amount of catecholamines, although rare, but may be helpful for the students in their exams. It is associated with few genetic conditions called multiple endocrine neoplasia, commonly known as MEN2 condition, von Hippel-Lindau, and neurofibromatosis. What are the signs and symptoms? So they have a classical triad: resistant hypertension, headache, sweating, and palpitation. So if your patient have any of these, just think of pheochromocytoma as well. So they may came in with chest pain, anxiety, glucose intolerance, and increased metabolic rate. The symptoms may be episodic, so it is sometimes quite challenging to diagnose this condition. How do you diagnose? Take a good history, physical examination, and the lab test. You need to check either urine metanephrines or plasma metanephrines. You have to collect urine for 24 hours. It is difficult. So most of the places use plasma metanephrine, but the drawback is very expensive. So still we rely on 24-hour urine collection of metanephrines. So when it is high, you should repeat. If it is on 2 occasions it's high, it means you have to confirm biochemically. Now you go to radiology to find where is the lesion. You need to go for CT or MRI of the adrenal, or next would be a special scan called MIBG scan to look for adrenal pheochromocytoma anywhere else outside the adrenal gland, which is called paraganglionoma. The treatment, usually we start with alpha blocker followed by beta blocker. So always you have to, this is again an MCQ question, always start with alpha blocker first, followed by beta blocker. If you may hypertension, usually start with a small dose, gradually tapers, gradually increase. And the few side effects of alpha blocker are dizziness, drowsiness, lightheadedness, postural hypertension, and tachycardia. This is one of the side effects of alpha blocker. So once patient develops postural hypertension and tachycardia, then you start on beta blocker. Propanol is still the drug of choice. You start with a smaller dose, then gradually build up. However, if the blood pressure remains high, you may use another hypertensive agent as well. And once you establish, then refer to surgeons for laparoscopic surgery, which is the treatment of choice. So once they have their surgery, and this usually the cure rate is quite high. Okay, now we move to the last section, calcium metabolism, and I'm going to discuss hypercalcemia here. So hypercalcemia, what the levels are? In Pakistan, we still use milligram per deciliter. However, in UK, we use millimoles per deciliter. So there are different values, so 8, 10, 12, 14, 16. So these are the milligram per deciliter, and in the bracket you see millimoles. So this is the normal calcium level from 8 to 10. However, if it is above between 14 to to explain this hypercalcemic crisis. And we sometimes use the corrected calcium or sometimes use ionized calcium as well, which not most of the people use, but this is the most commonly used. So how it works, the calcium, basically it is controlled by the parathyroid hormone, and the other hormone are vitamin D3 and calcitonin. It's caused by increased bone resorption, increased GI absorption of calcium, and decreased renal excretion of calcium. What are the causes of hypercalcemia? The commonest are hyperparathyroidism, which is either primary or tertiary. Primary is more common than tertiary, followed by malignancies. And then others causes are other granulomatous disease, vitamin D intoxication, and drugs. Always check the medication list, because most of the time patients are on these medication and came in with hypercalcemia, and you start investigating, which may prove to be unnecessary. Always look at good drug history. Lithium, thiazide, and vitamin A can cause hypercalcemia. So what's the best way to investigate? So once you have your blood test, which confirms that patient had hypercalcemia, take a good history, try to look for any disease, whether any history of cancers or not, and then any medication. As I said, medication is very important. Look for any over-the-counter medication as well. If patient has any, just stop, wait for a few weeks, and then check the calcium. If it is turned out to be normal, then it's fine. You don't need to worry. But if it's still high, then go for next step. The most important test is PTH. So again, PTH, if the PTH is suppressed, means it is non-parathyroid related hypercalcemia. And if it is high or normal or high, it is PTH related. So when it is PTH is not PTH suppressed, others could be different reasons like any malignancy, multiple myeloma. And if it is high, then either primary or tertiary hyperparathyroidism. There are others which I'm not going to detail, which you can read from this slide. The commonest are either primary or tertiary hyperparathyroidism or cancer. So PTH will decide. If the PTH is very high, despite hypercalcemia, ideally it should be suppressed. It is called primary hyperparathyroidism. If it is suppressed, then you're looking for any malignancy or myeloma. So treatment is start fluid hydration, because patient with hypercalcemia, the most important clinical presentation are polyuria, polydipsia, thirst, constipation, abdominal pain. So they are very dry. You start with saline, give plenty of saline. If the cardiovascular and renal function allow you to give at least 3 liters of normal saline per day, and then check your calcium regularly. If it is still high after 1 to 3 days, then you can try either diuretics or bisphosphonate, which will bring the calcium down within the acceptable range. Most commonly used are palmitoylate, either 60 to 90 milligrams. Others agent you can use are either calcitonin or erythromycin. It's not commonly used. And the others sometimes use glucocorticoid, or if the patient present with a hypercalcemia and renal failure, refer for hemodialysis. So what are the indication as an endocrinologist? We most commonly see the primary hyperparathyroidism as the commonest cause of hypercalcemia. So what are the group of patients need surgery? So these are the groups of patients which we thoroughly investigate and then refer to surgeons. If a patient has significant hypercalcemia, nephrolithiasis means it's affecting the kidneys, causing lots of kidney stones, decreased bone mass, serum calcium more than 2.7, or young age, or infeasibility for long-term follow-up. So these are the big group of patients. We refer to surgeons for definite treatment called parathyroidectomy, and we scan and look for any significantly enlarged parathyroid gland, which we thought is responsible for symptoms. So once we remove the gland, sodium calcium will come down normal. So this is a definite treatment. Otherwise, with medical treatment, you have to continue quite long follow-up. So, in conclusion, endocrine emergencies are relatively uncommon, but life-threatening. and pose a severe diagnostic challenge to the physicians. It's not easy. Sometimes it takes weeks or months to diagnose the condition, but if you have good background knowledge, you can do it easily. They need to be promptly recognized and treated appropriately. And careful, there is no replacement of good history. So good history and high degree of suspicions are the cornerstone for diagnosing such problem. And aggressive management of patient is important as complications are devastating and life-threatening. Thank you very much. Just to thanks again to organizers, which gave me the opportunity to talk you through. My email address is here. If you have any question, any comments, or any topic you want to discuss in the future, just let me know. I'm more than happy to do it with you.